Hello everyone and welcome to this discussion which relates to kneecap instability. I'd firstly like to introduce myself. My name is Sheila Strover. I'm a retired doctor and co-owner of the KNEEguru website and bulletin board. I'd like to introduce you all to my guest, Dr Lars Blønd, who is an orthopedic surgeon from Copenhagen in Denmark.
Thank you, Sheila. I'm really pleased to be here.
It's a great pleasure, Lars, and I'm sure that people watching will be interested to hear about your work. I'll just tell them a little bit more about you, and then I'll hand over to you. Dr. Blønd is a pioneer in the surgical procedure of arthroscopic trochleoplasty. Now that's a mouthful, but it means that it's a keyhole procedure that reshapes the bony groove in which the kneecap tracks. You see, in some people, an anatomical abnormality in the femur bone under the kneecap allows it to derail from its normal position. In the knee, even small changes in anatomy like this can lead to disabling symptoms, and in the kneecap, this is especially so.
Yes, this region of the knee is problematic, but it's a special interest of mine, and I'm proud to have developed some of the newer surgical techniques here. Kneecap or patellar instability is actually a rather complex topic. A person with an unstable patella can experience considerable misery. They may have frequent subluxation, or they may have one or more episodes of complete dislocation. A subluxation is when the kneecap feels unstable and pops up half the way, but never totally derails from the groove. A dislocation is a more catastrophic event where the kneecap jumps right out.
That must be so painful.
It is. In a dislocation, supporting tissue like ligaments may be ripped, and it can be very painful. This is very distressing for them. They feel that they cannot trust the knee anymore.
What would cause the kneecap to become unstable like this?
Well, several factors may contribute to a patella becoming unstable. As you know, the one I'm particularly interested in is trochlear dysplasia, where the walls of the groove are abnormal. In both these images, you see a normal knee with the patella contained in a nice, deep groove. In the image on the left, you're looking at the bended knee from above, where you can see the patella and the groove underneath it. In the image on the right, you're looking at the bones of the bended knee from the front. In both, you can see that the groove underneath the patella is concave in shape, which is normal. As you know, the one I'm particularly interested in is trochlear dysplasia, where the walls of the groove are abnormal. Another important condition is patella alta. In patella alta, the kneecap strides too high and doesn't really engage with the groove, although the groove may be normal. There are other conditions too that are important, but in this discussion I want to confine my attention lastly to trochlear dysplasia.
So in what way is the groove abnormal in trochlear dysplasia?
Take a look at the previous left-hand image again. Except now I have compared the normal situation to trochlear dysplasia, which is a new image on the right. Remember that the normal situation resembles the left image, which is a nice, deep, concave groove.
Okay.
Now the right image shows abnormal anatomy. The groove is abnormally flat, and the patella is no longer seated in it. In fact, sometimes it can be completely flat or even convex. This is what we mean by trochlear dysplasia. Now I will show you some scans of real patients. In these two scans, you can see a normal trochlear in the image on the left, with the patella safely in the groove. But now compare the image on the right. You can clearly see that there is no groove at all.
And the kneecap seems to be flatter and out to the side.
Yes, this trochlear is convex, so the patient has no bony constraint. It's easy to see how the patella on the right can dislocate. In the more severe cases, the groove needs to get its normal shape back. Otherwise, the patella will dislocate again and again. And with each episode, there may be more damage.
That must be terribly distressing.
Yes, you have to restore the anatomy by making the groove deeper. In this way, you regain stability of the kneecap and unload the high pressure in the knee. Both contact areas are covered in shiny white joint cartilage. High pressure on this joint cartilage is unhealthy for it. The cartilage will start to break down, and this will, in the end, lead to pain and arthritis.
Is trochlear dysplasia a genetic disorder?
Genetics is an important factor. One patient told me that her family could track patella instability 7 generations back on her father's side.
That's amazing. And so much distress for the family.
Yeah, actually, it's not uncommon. However, in other cases, there is no family history.
And are both knees usually equally involved?
No, in about half of the cases, it's only one knee that is involved, while the other knee is completely normal. These photos are taken through the arthroscope. That is why the pictures are around. They are from the same patient after surgery and before surgery. The photo on the right shows the trochlear in its abnormal shape. On the left is the same area immediately after surgical improvement. The tapes, the blue one, are holding the new groove in shape until the area heals up. One more strange factor contributing to the kneecap tracking incorrectly is that the groove in these patients is placed much too far medially towards the inner aspect of the knee. We have to shift it over to the middle.
Yes, I see that. Mm-hmm.
Another factor contributing to the kneecap tracking incorrectly is the trochlear bump where the arrow is. There's too much bone in the top of the knee, and this has to be removed.
So, besides making the groove deeper, trochleoplasty also involves removing this bumper bone and then bringing the cartilage back down into a better position. You sent me earlier a video showing a real live surgical arthroscopic trochleoplasty that you've done. I think this would be an excellent time for us to show it now, so I'm just going to pop that on and we can talk about it afterwards.
Hello, my name is Lars Blønd, and I will here demonstrate to you the arthroscopic trochleoplasty. This is the trochlear looking from above, and you see a flat and dome-shaped trochlear, and in the upper part you see the kneecap. Here I release the synovia over the trochlear bump. The trochlear bump is bone, too much bone, and in order to take away that bone, I first have to release the synovia. Here I smoothen some of the cartilage on the kneecap side. Now I have released all the synovia, and I can go in with my shaver burr. You will see it here. With this shaver burr, I can go in between the cartilage and the bone, and I'm going to release all the cartilage in the trochlear area from the bone. I just go slowly further and further until all the cartilage has been released in the upper part of the knee, and I have this cartilage flake. Having done this, I'm going to make a deeper groove. You see it here. And the groove is going to be placed in the middle of the knee and not on the inner side as it was before. Having made the groove deeper, I'm going to reinsert the cartilage flake, and I use these blue tapes and some blue sutures, and they will press the cartilage flake into the new trochlear. I have to say that these sutures and tapes, they are reabsorbed or dissolved in about 6 to 8 weeks. Now you see the outer side of the trochlear. I'm going to demonstrate to you the trochlear looking from centrally. And here you see a nice deep groove that fits to the kneecap. Though the kneecap doesn't look that well, that's because the kneecap has dislocated many times.
I need to point out that the huge majority of first-time dislocators are treated conservatively with a patella-stabilizing brace and physiotherapy. Even in cases where surgery is indicated, I usually reserve trochleoplasty for patients with severe trochlear dysplasia. More commonly, a different operation is appropriate, and especially MPFL reconstruction.
You've added in this something new, an MPFL reconstruction. What exactly is that?
Well, the MPFL is the medial patellofemoral ligament, the ligament that is most frequently torn with a patellar dislocation. It's a stabilizing ligament on the medial or inner side of the patella. When a patella dislocates, which is usually to the lateral or say outer side, then the MPFL ruptures. In cases with chronic instability, we usually find that the ligament has been previously torn or stretched out.
And how do you repair that, the MPFL?
The ligament can be reconstructed using different types of grafts. Today, I think it is the most common procedure for stabilizing the patella.
I understand that your main contribution is performing the trochleoplasty via keyhole surgery rather than via an open surgical incision. Is this better for the patient?
Yes. We now do this arthroscopic procedure as one-day surgery. And this is much less painful than the open procedure. What actually is painful is the MPFL reconstruction and not the arthroscopic trochleoplasty. I mean, when we do the MPFL reconstruction in combination with trochleoplasty, it is just as painful as any other MPFL reconstruction.
What then would you say are the main risks for trochleoplasty surgery?
I think infection is the biggest risk, but there is also a risk of arthrofibrosis, meaning abnormal scar tissue inside the knee. However, the risk is very low, and personally, none of my patients have had any of these complications.
Have any of your combined trochleoplasty and MPFL patients redislocated?
Not as far as I know, and I'm in good contact with all my post-operative patients.
And after the trochleoplasty, is there still a risk of cartilage breakdown or arthritis?
We know that the condition of trochlear dysplasia predisposes a patient cartilage damage, which is the beginning of arthritis. Although we only have 14 years of follow-up with open trochleoplasty, it seems that this procedure is likely to reduce the risk of arthritis developing in these patients. But with more time, we will know more precisely.
So what you're saying is that someone with this abnormal anatomy is likely to get some kind of cartilage damage, but that the corrective surgery reduces the risk and the severity.
Yes, this is an assumption based on the fact that the load on the two opposing cartilage surfaces is reduced. The recurrent dislocation is another factor that predisposes the patient to cartilage damage. Even in patients who have had a different procedure called TTT or tibial tuberosity transfer, some of the patients after 10 years or so will go on developing cartilage damage and pain. Actually, it's more than some, it's about half of this procedure, by the way, corrects problem of patellar alignment with the patellar tendon attached in a poor position.
To what extent is the pain improved after trochleoplasty?
After trochleoplasty surgery, this pain will be significantly reduced. However, for some there will be residual pain, mostly because of damaged patellar cartilage. In my series, the pain was reduced significantly.
Have you ever done the trochleoplasty procedure in the absence of patellar instability?
Actually, yes. 6 weeks ago, I did an arthroscopic trochleoplasty on a patient with severe dysplasia and pain, but who was not unstable. I've only twice done trochleoplasty for this kind of anterior knee pain, but it seems that it works pretty okay. The first lady I did had been in pain for 20 years, but was not trouble enough to agree to a total knee replacement. She was not that young, 46 or 47, and she told me that the pain that she had for so many years has just disappeared just after the surgery. The day after the surgery, she could feel that the normal pain was gone, so that was fantastic. The second patient has actually also responded well.
So in your opinion, patients with significant chronic anterior knee pain should also be investigated for dysplasia?
Yes, if they don't respond to physiotherapy, I believe so. It's not something that I have discovered, though. It was actually a surgeon from France, Dr Trochlear, who pioneered these trochleoplasty procedures for patients with anterior knee pain. Actually, a published study has nicely demonstrated that some patients with anterior knee pain has trochlear dysplasia, but very few surgeons seem to have noticed that study. This might explain why some patients with anterior knee pain fails to become symptom-free despite physiotherapy or the surgery that has been offered to them.
That's really fascinating. And I'm sure it will challenge patients to ask their doctors to exclude trochlear dysplasia if they have instability or chronic anterior knee pain. I know that we have a follow-up discussion for another video. Unfortunately, I think we will have to stop this one here now and look forward to seeing one another again on the next video. Thank you so much for explaining all of this so clearly.
It's been a pleasure, Sheila. I hope that my explanation were clear, and I look forward to future discussions.